Excellent. All right. So before we get into the individual unknowns, which I sent you, and I can send you all of this also, I kind of wanted to talk a little bit about what do we care or need to say, right, for salivary gland tumors, whether it be on biopsy or on resection. And so you're going to see biopsies on cyto, right, for FNA. You're going to see core biopsies sometimes of larger things in parotid. And you're sometimes going to see like shave biopsies or incisional biopsies of intraoral salivary gland lesions, right, that are like submucosal, right? So there are major glands and minor glands, right? Major glands being parotid, submandibular, sublingual, and then minor glands being all over the aerodigestive tract, right? So you're going to see either FNAs, cores, or sort of shaves. You always want to determine, right, whether something is truly neoplastic, right, or whether it's like inflammatory, reactive. Most of the salivary gland biopsies that we're getting are neoplasms, right? We're not getting too much stuff going on pseudoneoplasms. And so the question always then is it a primary salivary tumor, or is it possibly a metastasis to an intra or periglandular node? What glands have nodes in and or around them mostly? What are we mostly talking about? Parotid and sometimes submandibular, right? Usually sublingual, not so much, but parotid and submandibular, yes. Right, so these metastases are generally following the flow of lymphatic drainage from the scalp. So ear, head, eyes, cheeks, right? All of this skin drains out to the parotid and then down. So you're dealing with things like squamous or basal cell carcinomas, melanomas, even Merkel cell can pop up in the parotid, right? So always just have that in the back of your head. This is not the majority of cases, but you will see it. You can get mucosal tumors like HPV or EBV, or even just conventional squamous cell carcinomas of the mucosal sites, sometimes draining outward, but usually those drain lower in the neck, right? Like 2, 3, 4, 5. So usually we're not dealing with parotid. While we're here, what anatomic level of the neck is the submandibular gland? Level 1, right? So when you see a level 1 neck dissection, know that that will generally include submandibular gland. If it's a benign submandibular gland, non-neoplastic, you can select 1 or 2 representative sections. If they're taking level 1 out for a submandibular gland neoplasm, right, sometimes that's how it comes. It comes as resection of level 1. So always be aware, is this coming as a neck dissection because the patient has like a tongue cancer, right? Or is this coming as a level 1 because the patient has a submandibular lesion? So always just ask yourself that question 1. Parotid's generally not going to come out as a neck dissection with other things, but submandibular is. Okay, so that's thing 1. Thing 2, once you are dealing with, okay, this is I favor primary salivary gland neoplasm. Generally, anything that's a benign or even a low-grade carcinoma is just resected with margins and no neck dissection. Once you get something that's overtly high-grade, these are going to get a neck dissection and generally wider margins. And sometimes they have nerve involvement, whatever. And then sometimes we're in this other category, especially you'll see this on cyto, right, where we have something that's kind of cellular and maybe basaloid and maybe like has features that could be anything from like pleomorphic adenoma to a low-grade basal cell neoplasm, all the way to an aggressive adenoid cystic carcinoma. And it's the adenoid cystic carcinomas that we want to be careful about because they may take wider margins and or neck dissections because of the propensity of these things to travel. So in this institution, when we see basaloid, not overtly high grade on biopsy, and we can't tell, they'll trigger the molecular testing for the RNA fusion that will intend to pick up the MIB or MIB-L1 NFIB fusion to isolate adenoid cystic, in which case the surgical procedure might be different. But in doing that, we've found mutations or fusions, right, that are diagnostic of pleomorphic adenomas or other things. So in our particular instance, right, this fusion panel can pick up a lot of different things, but the main goal, right, is to rule out this. Okay? Okay. So when we look at salivary gland neoplasms, I tend to always run through in my head, like, all right, where are we anatomically, right? Because some tumors don't occur in some sites. Are we dealing with a monophasic or a biphasic tumor? And then what other sort of features are there that we can think about? And so I'm gonna be like a broken record here because my 3 stains, right, that we generally always start with in salivary are gonna be things like P40, CD117, and S100 because it will sort you out into the most common categories. The biphasic ones, meaning that there's a myoepithelial / basal cell population that's P40 positive and a luminal or epithelial population, right, that's c-KIT or CD117 positive. Then there are the tumors that are dead P40 negative. That's a whole different monophasic beast. Then there are the tumors that are diffusely P40 positive. That's a different monophasic beast, right? That's sort of a squamoid or basaloid. This is more of a glandular phenotype. And then within that, there are ones that are diffusely S100 positive and S100 negative. So you can at least minimize your differential diagnosis by those 3 stains into like buckets, and we'll look at what those are. The oncocytic ones are morphologically oncocytic, and those can kind of be in any one of these 3 categories. So of the biphasic, right, biphasic again meaning both epithelial and myoepithelial cells being part of the neoplasm, this is a lot, right? There's a lot of tumors, anywhere from the most common salivary tumor, right, which is pleomorphic adenoma, to our basal cell neoplasms, to, right, our adenoid cystics, epithelial, myoepithelial, and then some new ones and some rare ones. Sclerosing microcystic, intraductal, these intercalated ductal sclerosing adenomas, these are pretty rare, right? Mostly we're gonna be here. And many of them have defining mutations or fusions. So just like lymphomas and sarcomas, right, salivary gland carcinomas and adenomas are developing these well-known, not developing, we are understanding what mutations and fusions they have. So those can also be helpful in an event of diagnostic uncertainty. And this is like everything in the WHO, right, for salivary neoplasms. The monophasic ones that are one cell type, right, are either those that are P40 negative, so they don't have any true basal differentiation. The reason we don't use P63 in these is that they can be aberrantly positive non-specifically. So P40 is the true, in salivary gland, is the true basaloid, true myoepithelial marker. Amongst these, there's the ones that are S100 positive, like secretory, polymorphous, and or microsecretory, and the ones that are negative, like acinic and mucinous, and then some rare ones on the side. But they're all sorted, right, by S100. And then those that are usually P40 diffusely positive, things like hyalinizing clear cell carcinoma, often myoepithelial carcinomas. These must show, right, some other evidence of myoepithelial differentiation, whether that be the contractile markers, right, or the sort of neural cresty S100 SOX10 markers. These other ones, right, don't have this, right, so that's unique amongst these. Mucoep is one of those that should be diffusely P40 positive because it has this sort of intermediate and squamoid cell phenotype, but also mucin, right? And then lastly, right, always considering metastatic squamous cell carcinomas to the parotid. True squamous cell carcinomas of parotid probably don't exist. They're probably all metastases or some other like basaloid variant of something else. And then the oncocytics, right? So the true oncocytic lesions of salivary that exist nowhere else, right, are oncocytoma and Wharton tumor. We know that those are truly actually biphasic, right? They do have a P40 positive abluminal cell layer that stains the cells that are near the stroma. And then all of these others are oncocytic variants of the other tumors that we have seen or will see, right? Oncocytic PAs, oncocytic mucoeps. So this will be here all for your reference. These are the most commonly described oncocytic variants of other tumors, okay? And then to flesh out the last things that are in the WHO that are very rare that you may or may not see, right, are things like the other lymphoid-rich things like sebaceous or non-sebaceous lymphodenomas, and these very other rare tumors that are mostly sort of intraductal, cystic, papillary types of situations. Okay, but I need you guys to know the most common ones. So that's kind of what we're gonna focus on. Questions? Okay.
I really like this this
Algorithm.
algorithm. Because previously we have the table that's kind of overwhelming.
Yes.
This is great.
Oh, good. Thank you. Yes, the table of everything is overwhelming. I think the algorithm is nice. So look out for, I'm in the process of finalizing a manuscript that is a paper on this. So it'll be coming out at some point later this year, and you can have it in your stock. And I'll send you this so you can have this presentation also. But all of these figures are also going to be in the paper. Okay, good. I'm glad you like it. Okay. In sake of time, rather than having you guys come up here, I'll drive it, but I want you to tell me what you see. Okay, is that fair enough? All right, we'll do a hybrid. Okay, so this is a shave biopsy of an intraoral salivary gland tumor, right? And we know that because there's some squamous mucosa and some minor salivary gland. So I don't even need to know the history. I can sort of tell you where we are already just based on those features, right? You have some mucinous glands here and some ducts. So when you guys see this, what are your sort of immediate thoughts? Shout things out.
Solid groove. There are these kind of like interspersed kind of sclerosed kind of stromal bits here and there. There's not like a discrete capsule. There's nothing like a border where it goes from like tumors to non-tumor.
Yep.
And then there's a little nodule budding off there. And then in terms of the cell morphology, I don't see any necrosis on high power scan. But a lot of these cells have a very kind of rhabdoid look to them. It's favor a low grade tumor right now. Yeah, so I don't know. I guess like I kind of wonder if this is some variant. Is this some kind of myoepithelial thing? Like it looks like it's more hard to tell if it's monophasic or biphasic. Most of these cells are rhabdoid looking, but then a few of them have less cytoplasm.
Yep.
So yeah, I guess that's kind of where I'm at morphologically. I don't know if you want like a differential right now, or if we're just gonna go to stains. Or...
yeah, we can move to stains, since we're gonna throw the same stains on all of it. But you know, you already talked about, is this something purely myoepithelial, or is this a myoepithelial rich variant of something else? These rhabdoid cells are sometimes referred to as hyalin or plasmacytoid myoepithelial cells. Hyalin, right, because the cytoplasm is very glassy and smooth and pink. And so this is very, very common in the tumor that this ends up being. So we have a very cellular tumor. We have hyalin or plasmacytoid myoepithelial cells. We have some hyalinizing stroma in the background. And we have these areas that we may ask ourselves, okay, there are some holes, right? Are these true ducts, or are these just sort of holes, okay? So in minor salivary gland, tumors may be unencapsulated, but still be benign, right? So that's an okay thing. So if we're gonna go with our, like, I don't even wanna come up with a differential yet. I just wanna throw my P40, my C-kit, and my S100 on. Fine, you win. So here, let's check our normal control, right? So that's nuclear in the tonsil, so that's P40. And when we come over here, well, most of those hyalin or plasmacytoid myoepithelial cells don't have P40, but that is not uncommon. So we want to look for areas that might have P40. Aha. Okay. Does this P40 to you seem random, or does it seem like maybe there's a geographic distribution? Yeah, maybe a little geographic distribution. You have this sort of stroma here in the background. You have these kind of complex structures, and it looks like the P40 is kind of present, I mean, maybe the outside, right, or maybe near the stroma here. And it's totally dead negative in these plasmacytoid myoepithelial cells. So then you have to ask yourself, right, is this P40 expression, are these entrapped non-neoplastic ducts, or do these look like possibly neoplastic?
Neoplastic.
Probably neoplastic because why?
There's no kind of like interface that separates them from the rest of the tumor, it just kind of all blends together.
Yeah, there's no discrete interface. It's a very complex architecture, right? You wouldn't expect non-neoplastic ducts to have this ramifying structure, right? So these are probably neoplastic ducts. So now you're dealing with a biphasic tumor, exactly. And when you throw your CD117 on to see in contrast if there are epithelial cells, then we're gonna go to that same area, right, where we saw the myoepithelial cells, and we'll say, okay, in fact, there are tightly packed clusters of what look like possibly luminal epithelial cells, right? And you might be able to imagine that the negative cells out here might have been those P40 positive ones, right? So it's kind of, unfortunately, right, we don't have the overlay, but we have at least a c-KIT positive population and a c-KIT negative population. And then over here, similarly, a c-KIT positive population. So at least focally, we are biphasic, even though the vast majority of this tumor doesn't seem to be staining with anything. Here's another little c-KIT area, right? Again, showing maybe actually ductal lumina. Gosh, it's not so easy to see on these guys, right? These little ductal lumina surrounded by c-KIT positive cells. So we have biphasic ducts, and then we have this sea of plasmacytoid myoepithelial cells that is usually strongly positive for our lovely third marker, right, which is S100. So the hyalinizing plasmacytoid myoepithelial cells in this tumor are S100 positive and usually P40 negative. However, the myoepithelial cells that are surrounding those bilayered ducts are the ones that are P40 positive. And so this is the geographic distribution that we like to characterize in these biphasic tumors, okay? So what are we narrowed down to now? What are we favoring of our biphasic?
But carcinoma?
So you're thinking epithelial myoepithelial carcinoma, okay? What?
Pleomorphic adenoma.
Pleomorphic adenoma. What else? Does it look like adenoid cystic, performing blue? Not really, right? So in this case, my favorite morphologic diagnosis is PA. Epimyoeps don't usually have these hyaline or these plasmacytoid myoepithelial cells. That's usually pretty good for pleomorphic adenoma. And with that being said, you can have duct or epithelial pore variations of PA, which this probably is, right? And you can have epithelial pore variations of epimyoep. However, those plasmacytoid myoepithelial cells are pretty characteristic of PA. So here we have the resection of this tumor, which shows a relatively circumscribed edge. But remember, in the minor salivary glands or in the palate, you don't have to have a clean encapsulated edge. You can have a little bit of a blurry edge, and these things are still benign. Up at the top, right, this is where the incisional biopsy was done. So we kind of expect maybe there to be a little bit of a blurrier line, right, because that's where they cut through, and that's where the scar, in fact, is right under the mucosa. All right, so there was a lot, that was only the tip of the iceberg, right? There was a lot hiding underneath here. And so if you wanted to repeat those stains on the resection with your P40 and your c-KIT, right, you'd find similar similar findings, right, where your P40 has this ramifying pattern. However, right now at the edge, you probably have some normal ducts, right, with a very clean architecture. You have your c-KIT or your CD117, which stains some of the luminal epithelial cells and, right, the epithelial cells of the background ducts, and your S100 with your plasmacytoid rich areas. Okay, so comments, questions, thoughts. You can peruse these more on your own, but for sake of time, we'll right? Pleomorphic adenomas can take on a variety of appearances. That's why they're called pleomorphic, right? They're not called pleomorphic because they're anaplastic pleomorphic. They're pleomorphic because they're sort of architecturally and cytomorphologically heterogeneous. Even if you don't see good cartilage, right? We tend to think, oh, pleomorphic adenomas have a lot of chondroid or myxoid stroma. They do, but not always, right? Not in the cellular variants. This happens to be a cellular, like hyaline myoepithelial cell rich variant of PA with only focal dots. What else?
Variants predict like recurrence.
No. What predicts recurrence is margin status. So this is one of the benign tumors that I will always report margins on because that is what predicts recurrence. Pleomorphic adenomas, right, we know, can have pseudopods, right? They don't have to have a perfectly rounded border. They can have these pseudopodia-like projections into the nearby tissue and still be benign, but those things might be an indicator of recurrence, right? Whether or not they have potentially little pseudopods or little satellite lesions that might not have come out in the primary excision and be left behind, and then they regrow.
Do we have to worry about like mesenchymal thing, stuff mucosa tissue when you see this pathology? I mean, not just like rhabdoid looking, but also, yeah.
I mean, if you see something that's hyaline plasmacytoid in a mucosal site, I'm not super thinking like a rhabdo, right? Because it's pretty bland. Or like the other thing you could think about is like in one of the INI1 or SMARCB1 deficient neoplasms, right? But if you're in a salivary site, you're mostly going to be dealing with this. But yes, depending on where you are and what the morphology of the plasmacytoid cells are, you can always think about something like a rhabdo or a chromatin complex remodeling INI SMARC deficient fit. But this is so low grade, and in this context, I wouldn't. If you're looking at like mesenchymal cells, like myxoid, yeah, you can always think about something mesenchymal as your myxoid myoepithelial cells, but usually you'll have something like S100, SOX10, P63, or P40 that will direct you that like, oh, these are probably just myoepithelial cells rather than mesenchymal cells, right? Because myoepithelial cells can be spindled, and we'll see that later. Oh, I do want to point out though that once you know you are in a myoepithelial rich tumor, right, which this is, you'll read about myoepitheliomas of salivary gland. You will notice that I do not have myoepithelioma of salivary gland on my list because I'm not sure that it exists. I think many of them are either duct-pore pleomorphic adenomas or myoepithelial carcinomas. We can get into that later, but you'll notice that's why that's not on there. Okay, next.
I can describe.
Thank you.
So it looked like they weren't really clear borders. We're getting just all tumor in this specimen. It's a proliferation of sort of nested islands of gland. Some are more solid, some are trying to cribriform, and they might describe it as like sort of chromatous, maybe with interweaving myxoid background. As far as
I have no idea what happened. Okay.
I was like looking around to see if I saw like any like PNI or other like features to give me like a better idea of how aggressive it is. Because it looks relatively bland. The cells themselves, sometimes they have sort of nuclear inclusions or sort of cleared out nucleoli. Some variability in size, but I was trying to figure out, is this like monophasic or biphasic? Because we have the sort of acinar looking things, I'm thinking it would be biphasic when we stain it. But I'm always like, I'm still like, so like, what looks like this? Even though I know salivary can look like a lot of different things. So I guess I was thinking of things that look sort of basaloid, just be this is very like purple. So kind of like, I was thinking about adenoid cystic. But I know like pleomorphic can look like this, so I think the differential could be relatively broad.
Yeah. exactly, right? So a very, very blue basaloid thing with pale bluish mucoid stromal material and these sort of tubulo-trabecular or cribiform spaces, there's a mitotic figure, right? Should at least raise very high adenoid cystic, right? Because that is the most common tumor that has these combinations of patterns, the tubules, the trabeculae, and the cribiform with this myxoid matrix, right? So remember, you have basement membrane material or connective tissue mucin that's being secreted in all directions, right? So you have connective tissue mucin that's being secreted out here into the stroma. You have this connective tissue-y basement membrane-y pink material, right, that's being secreted into the holes of the cribiform spaces. All that is matrix material being secreted by the cells of the tumor. So you want to at least prove to yourself that it's biphasic. So in this case, you have a glorious looking P63 that's present at the periphery of these nests. If you'll note, P40. If you'll note, there are P40 positive cells at the outer edge of the cribiform space, right? And there are P40 positive cells, at least focally, right, rimming this cribiform hole, which means there are myoepithelial or basal cells sandwiching, right, the epithelial cell compartment and secreting the bluish connective tissue mucin out into the stroma, right, and secreting the pinkish basement membrane mucoid material into the holes. Yeah? All right. So it's like basement membrane in all directions. All right. So that's beautiful biphasic cribiform. So at least you know it's biphasic. You're morphologically in a position of this looks a lot like adenoid cystic, but I know that pleomorphic adenomas can have those types of areas. CD117, ridiculously strong, right, in the epithelial compartment. So when you read about CD117, yes, it's strongly positive in the epithelial cells of adenoid cystic, but like we saw and will see continually, it is also equally strong in the epithelial cells of non-adenoid cystics, right? So don't let c-KIT drive you to only adenoid cystic. And then S100, in this case, is not helpful. There's no population here that's specifically S100 positive or specifically S100 negative. It's just kind of randomly there. And importantly, there's nothing that's S100 positive going on in the background stroma. We'll see why that's important maybe later. Okay? So if you were like, this is a basaloid biphasic salivary neoplasm, I'm going to send the MIB NFIB fusion. In this case, you'd be lucky because it would have been positive. So in this case, you're dealing now with a resection of an adenoid cystic. And in this case, it's generally circumscribed. However, right at this little edge, there's definitely infiltration, right, that's heading out towards the normal salivary. You have these beautiful, beautiful cribiform spaces. Right? You have some 1, 2 mitotic figures, right? So now you're asking yourself, how do I grade this thing? So grading, first of all, is everybody okay with this being adenoid cystic? Okay. Grading of adenoid cystic is generally, is it predominantly tubular, right, like this, where you just have these bilayered tubules? Is it predominantly cribiform, or is it predominantly solid? And that's kind of the tiered grade. However, they're all kind of considered bad. They can all have P&I. They can all track backwards up into the brain. Then for like any salivary tumor, you have to ask yourself, is it worse? Meaning, does it have like overt dedifferentiation or high-grade transformation? Overt dedifferentiation or high-grade transformation in salivary means I can kind of no longer tell what it is. It has lots of mitoses. It has lots of prominent nucleoli. I would say this isn't quite there yet. I can still tell it's adenoid cystic. So I'm not going to call it D-diff, but I'm starting to notice, right, that there are scattered mitotic figures and that there is coarse chromatin in areas, So we might suggest that this is on its way, right? But there's no good, clear grading system for these. So we sort of have to be descriptive in many instances. We don't see overt necrosis, right? But we do see some cytologic features of maybe this is creeping to high grade in terms of its, mitotic. Questions, comments?
Yeah. Section, if there's like PNI or other high grade features, do they just watch these or do they treat them with?
If there's PNI, they'll usually at least radiate them. Because though that stuff could just track back, right? It's all cranial nerves, right? So it's tracking backwards into the brain. So they're pretty aggressive with adenoid cystics.
What do you suggest us or suggest to do if there's a baseline neoplasm on the FNA
Mhm.
and then the mid are negative?
Then you can't prove it's adenoid cystic, right? So you can at least just say this is a basaloid neoplasm. There's no MIB fusion. I can't call this adenoid cystic, but theoretically it's still in the differential because not all of them have the fusion, or it might be cryptic. So it would be uninformative. If it has something else, like HMGA2 or PLAG1, that's helpful, right? But if it has nothing, then it's unhelpful. And they'll have to manage clinically, right, with what they feel clinically is happening. Those are the cases in which sometimes they freeze, where they're like, I don't know. The other day, we had a quote unquote low grade salivary neoplasm on FNA. And I guess they went in and it was like not behaving low grade. And they're like, oh, dude, it's like stucking on the nerves. So they're sending frozens, right? They're sending frozens on this quote unquote low grade salivary neoplasm on FNA. And it ended up being like salivary duct. It was all over the place, right? So mostly our biopsy is correlative, but sometimes the cells are scant. Sometimes the problem with salivary, right, is sometimes even if the cytomorphology of the cells are bland, the biologic behavior can sometimes be unexpectedly aggressive for the cytomorphology of the cells, right? It doesn't always, if it's overtly high grade, necrosis, mitosis, yada, 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 that's helpful, right? But sometimes it can still be morphologically somewhat cytologically bland and still be somewhat biologically aggressive. So that's the problem with salivary, to be honest. One of the problems.
So I remember that case of
Yeah.
frozen.
Yeah.
So do you think that putting the low grade baseline neoplasm in the FNA, that will turn out to be a sample, so it's not exactly baseline?
Correct. That is the outlier. So when we retrospectively looked at our salivary FNAs and core biopsies, mostly the qualifiers of low grade, high grade, and basaloid were correct. So there was always an outlier where something low ended up being high. Not so frequently did something high end up being low, right? Because you can see it. But over 90% of the time we were right. So if you think low, if you think high, and if you think basaloid specifically, those three groups are good. And then we test the basaloids. Yes, you will always have an outlier, but in the majority of time, those morphologic features will be right. Most of the time.
Wonder we should have a different character to put those in.
Yeah.
It's not sure it's high grades, it's basically.
Yeah. Well, yeah, there's always different ways to operate. I don't know that the Milan system, right, like the sumps, I don't know that those are very helpful, honestly. Which is why we don't use that. We use low grade, high grade basaloid, right? Or other descriptive. And in most cases, those diagnostic groups will catch the majority of common tumors and their biologic behaviors, right? Mostly we're catching PAs, adenoid cystics, basal cell neoplasms, right? Very rarely we're gonna go wrong, but it happens. Okay. All right, next case. So here we're dealing with a lot of these intraoral, like these sort of palatal or minor salivary gland biopsies, because I'm not sure how often you guys see these. Sometimes they pop up on Mark Lingen's service. So I wanted to give you the opportunity to look at them. So again, we're dealing with a mucosal site with very remarkable, prominent mucinous glands. So anatomically, I know we are in the what? Minor, and most specifically in the oral cavity, where probably are we? Palate. So sublingual does have prominently mucinous glands. However, palatal glands are 100% mucinous. So if you're dealing with a mucosal site where the mucinous glands are right up on the palate, right up on the mucosa, probably it's palate. Okay. And now again we have this sort of circumscribed-ish but unencapsulated tumor with dangerous closeness or even positivity at the margin. All right, so just one thing to note. So who wants to describe this one?
I can go again. Yeah, I guess on low power, it looks like it's got some areas that are a bit more kind of cystically dilated. There's areas of solid growth. There are maybe some areas where it gets a little bit tubular. Oh, that's interesting. If we go to high power, there's like, there's like kind of a slit, like kind of gland off to the side.
Oh, this?
Yeah, I'm not sure what's going on there exactly.
Yeah.
So it looks, I favor it's a monophasic tumor from what I'm seeing so far. Nuclei look pretty low grade, kind of vesicular chromatin. I'm not looking for like roots or any other features. No mitotic figures from quick scan. Yeah, I mean, I guess there's kind of like hyalinized stroma here, some myxoidy stuff, some single selling. So I'm thinking, like, given the site and the variety of growth patterns, like, I always go to the uncommon things first, like polymorphous adenocarcinoma, the first thing that comes to mind. But I guess it could be like a PA or something too. That's like single cell type predominant.
Yeah, exactly, right? So that's where our first round of stains is going to help, right? So this sort of, I don't know, I kind of think of it as like cloud-like, right? There are these sort of large, voluptuous kind of nests that are almost cloud-like, and the stroma is this very pale pink, pale blue, pale purple, and the cells themselves are very monotypic. There's a mitotic figure with this kind of open chromatin. And in the areas of ducts, you know, I'm not 100% convinced that I see those nice 2 cell types. So in that case, a monophasic neoplasm of the palate is very likely going to be something like polymorphous. So if you throw your P40, like I will always throw my P40 on and essentially find it in these large islands and nests to be negative. And so then you ask yourself, what are these doing? Excellent question. They're there. Are they entrapped ducts? Maybe some of them are. Maybe some of them look like they're staining the myoepithelial cells. Some of them definitely, right, are background myoepithelial cells of ducts. So this stain was a little bit confusing because it looks like there's some random P40 being grabbed, right, in the tumor, but it's not diffuse. All right, well then let's look at our this has to be P63. Yeah, so when you look at P63, right, that's a mismatch. That's a horrifying mismatch, right? So when you think about true myoepithelial differentiation in salivary tumors or squamous differentiation in salivary tumors, P63 and P40 match, right? P63 and P40 match. In this case, P63 and P40 don't match. So P63 is staining everything, and P40 was like, me. So to me, that's a mismatch, and I'm favoring that this is really mostly a P40 sort of non-expressor. However, as a P40 generally non-expressor, it is an expressor of, what would this stain be in your example? S100, right? So this is S100, diffusely staining nucleus and cytoplasm of tumor. Okay, so that would be the phenotype, morphology, and immunohistochemically, right, of essentially a likely monophasic. I don't know what that random 5 P40 positive cells is doing. Diffusely S100 positive, polymorphous. So this had, is my infrared, do I have a little eye here? No. What, if you were uncertain, what kind of mutation or fusion would you be looking for? PRKD1 mutation or fusion, exactly. I believe this had the fusion. So we're like, okay, I don't know what those P40 positive cells are doing there. Morphologically, this is polymorphous. The P63 and the P40 are a mismatch, and the S100 is diffusely positive. Does it matter if I call this a low-grade monophasic, likely, monophasic salivary neoplasm with a positive margin? Probably not. They're probably going to treat it the same. They're probably going to have to, however, if you're now calling it a carcinoma, they'll probably go back for this margin. If you're calling this a pleomorphic adenoma, they might not. They might watch and wait, right? So in this case, it might be useful to make that distinction, but we sort of favored this morphologically to be polymorphous, regardless of whatever those 5 P40 cells are doing there. Yeah.
Is P63 usually this strongly positive and diffuse? Because I feel like a lot of the texts or a lot of the resources that I've seen, they usually describe it as being like focally positive.
I've seen it diffuse positive, I've seen it dead negative, and I've seen it patchy positive, which is why I don't use it, because it's not predictable. In this case, it was kind of helpful to show that discrepancy between the P40, right? But I don't use it because it's not reliable. It's not reliably, not reliable. So yes, all of the above. Okay. 15 minutes. Another minor salivary gland, very mucinous, potentially also palate. Very circumscribed, right, like a cannonball. What's different now? Does it have this sort of multilobulated cloud-like phenotype? No, pretty uniform and rigid. But it does have these little microcysts, right, or these little microducts. It doesn't have this sort of connective tissue mucin. It mostly just has this pale stuff in the lumen. And morphologically, kind of monotypic. Does anybody right off the bat on H&E know what this is?
Secretory
like a secretory?
Secretory carcinoma, yes. So how can we prove it, right? So this is classic appearance of secretory carcinoma with these monotypic sheets of cells, little microcysts and microtubules, but really no other good like macro architecture. So we're going to prove that it's P40. Again, pretty negative. Maybe there's some entrapped something here, but mostly around these tubules, right? We don't see any biphasic layering happening. This is another one of our diffuse, strong S100 positive tumors, right? So P40 negative, S100 positive generally go together. And the other stain that this now we're going to add on yet another stain because it's specific to this tumor, which is mammoglobin, right? Exactly. So mammoglobin. So what are the genetic drivers in secretory? TV6 and TRAC3. So we care about NTRAC because it can be used as targeted therapy. In a low-grade secretory with negative margins like this, no one's going to use NTRAC therapy, right? But in a high-grade secretory, one may consider it. All right. Right. Next. We have a little salivary here, which is maybe kind of mixed seromucinous. We have, again, kind of a circumscribed thing with, again, this microcystic pattern. What do you notice that's different? Stroma. Stroma? The stroma, right? The stroma is very spindled in the background, which we kind of haven't really seen yet, right? So now we have this almost secretory-like pattern, but with this kind of fibrocellular stroma in the background, which is kind of interesting. So just keep that in your mind. This is one that we may or may not know right off the bat, but we're gonna do our stains. So let's double check that this is P40. We have, yep, there's our positive control, okay. And again, right, P40 negative. But similar to the other case that we just saw, right, what do you now expect this stain to be? P63, right? So this discrepancy between P40, P63 that some people like to show, but again, I don't need to show it because I don't care what P63 shows. Why can I not recall what this is? Right, neither. Is this S100? No. Oh, I know what this is. Okay. So what nuclear marker stains serous acini and select tumors? We haven't talked about it yet. It's not S100, it's SOX10. SOX10. So I tend to not use so much SOX10 in salivary because it kind of stains a lot. As you can see, it stains just normal ducts and acini, but it also stains some tumors. But this is an example of where SOX10 was done. So we have a morphologically P40 negative, monophasic, kind of secretory-like looking tumor, but with this fibrocellular stroma in the background. Does anybody know what this one is?
Microsecretory?
Microsecretory. Exactly. So this is relatively newly described and pretty rare. But it's in the it's in the P40 negative S100 positive group. And it is defined by this, those glands looked a lot like secretory, but it has this fibrocellular stroma, and often it has these SS18 fusions. So this is microsecretory. You may or may not see it ever, but now you've seen it. All right. Moving on to another mucosally surfaced tumor with lots of inflammatory cells and some kind of adjacency or entrapment of ducts. A lot of glycogenated question mark mucinous clearish cells, right? Admixed inflammation. You see any good structures? Or is this mostly sheet-like?
Mostly sheet.
Okay. Anybody want to throw out a differential, or do you just want to see what the stains show?
Hyalinizing clear cell carcinoma.
Okay, tell me why you think that.
Just the background is, it's pretty collagenous looking. It's not like not terribly myxoid or anything. Clear cells that we have, and I think they can be a little inflammatory as well.
I guess like a clear cell variant of like a monoepithelial carcinoma is also a differential that.
Yep.
This is like some weird solidly growing mucoep. It's got, these are actually mucinous cells.
Yep.
Not really seeing great like squamoid cells here.
No.
I think it's not true.
Yeah. Excellent. Right. So you're seeing solid sheets, no structural differentiation, not really any ducts or nests or cribiform. Question mark? I don't know. Is that a duct? Is this a mucinous cell? Not sure. I think hyalinizing clear cell carcinoma. I think a clear cell myoepithelial carcinoma, and I think a solid mucin poor mucoep are all on the differential. The problem is, what do all of those stain for? What should all of those stain for? P40, right? Those are all in the sort of basaloid, squamoid area, right? So P40 diffusely positive. So now how are we going to differentiate between, let's see, hyalinizing clear cell and myoepithelial? What other markers were on that list? This chart. S100 SOX 10. So you're like neural crusty stains. And then you're
Hyalinizing clear cell should have it's like component, SMA, it's like that.
correct. It doesn't have them. So hyalinizing clear cell, while it's morphologically somewhat maybe myoepithelial-like, it is immunophenotypically not, right? So HCCC is negative for the contractile markers, right? Negative for SMA, calponin, Desmond, whatever, and negative for the S100 SOX 10. Whereas myoepithelial should have some of them or one of them, right? So just P40, P63 being positive doesn't necessarily mean it's myoepithelial. Do your myoid, do your S100 SOX 10s. You got to find another one of those. Like in all of, this is just, I haven't even mentioned keratin because it's positive and everything, right? So I don't tend to use keratin per se when I know I'm dealing with an epithelial neoplasm, right? But let's say you're in soft tissue of the thigh. You can get myoepithelial tumors of somatic soft tissue, in which case keratins can be very helpful, right? To show that these are myoepithelial, right? When you're in a salivary site and you kind of know you're dealing with something epithelial or myoepithelial, I don't tend to need a keratin. However, by definition, something myoepithelial should have keratin, right? And the other markers, all right? Just to put that out there. So in this case, those are negative. SMA, calponin, S100, SOX 10 negative. Now, if you're thinking about, could it be that would also be true for mucoep. Right? Mucoep should also be negative for those additional myoepithelial markers. So maybe you want to look at a mucin stain. I think we saw like one intracellular mucocyte, right? So we're like, all right, is this a low-grade cell? Is this a solid mucoep, or is this an HCCC? Who wants to place a bet? I already owe people beers on Wednesday, so
Mucoep, solid mucoep.
we got to vote for solid mucoep. Mucoep.
Highlighting
Hyalinizing clear cell. We already know what your vote is because you already said it. Mucoep.
Yeah, I'm gonna say
Mucoep. All right. What fusion are we looking for? Mammal 2 versus EWSR ATF, right? EWSR ATF is HCCC and Mammal 2 EWSR. Okay. All right. So this is hyalinizing clear cell carcinoma with one mucinous metaplastic cell. Okay. So excellent job though, right? This is exactly the process that we go through. Regardless, it's carcinoma, right? There's nothing morphologically or immunophenotypically that's benign. So we know it's at least a low-grade carcinoma that is, abutting, if not, present, at the deep margin. So question mark, are they going to watch it versus re-excise? Usually this close, they'll re-excise for carcinoma. So this is hyalinizing clear cell. I don't recall what stain this was. Oh, this was S100, right? So dendritic cells and Langerhans cells in the epithelium, and these like spiky dendritic cells in the background. So I just wanted to prove to you that this was not showing any myoepithelial differentiation in the tumor, right? All of these little spiky guys with spiky cytoplasm are the dendritic cells. So this is a nice example of HCCC. This is a more like overt classic example of hyalinizing clear cell carcinoma, where like every single cell, right, is optically clear, and there are giant bands of hyaline in the background. Right, but not all of them look like this. But this is one example that is read the book. All right, now questions. Now we have I believe this was either intraosseous with mucosal involvement or vice versa, but I believe that this might have been one that was focally at least involving bone of the mandible. Mucoep, right? You shouldn't, top 10 diagnoses here are mucoep. How do we get there? So, cystic, both macro, right, and sort of small microcystic. Remember that mucoep does not have to be cystic, right? It can be solid, but in most cases it's cystic. In most cases, the epithelial lining is sort of multi-layered, right? It's not mono or bilayered, it's sort of multi-layered. It has these very eosinophilic cells that are kind of squamoid, right? It has nice mucin everywhere, right? Mucin everywhere. And so in the lumen, you have this mucoid stuff. Lining the edges, you have tons of mucinous cells. But you want to be able to see the multi-layering of the squamoid and or intermediate cell population. Intermediate cells just mean they're kind of nondescript. They're not really squamous, they're not really mucinous, they're just kind of there. They've got some cytoplasm, right? Those are intermediate cells. But yeah, this had mammal tooth fusion. So this was an example of a nice kind of macro and microcystic intraosseous mucoepidermoid carcinoma. So when you see this kind of morphology, whether it be in a jaw cyst or in a salivary cystic neoplasm, right? Mucoep times 10. Okay. Versus mucin, right? Mucin, tons of extracellular mucin, but okay, we're good. This kind of complicated papillary structure. These little cells that sort of slough off in the mucin. So if you were to throw this in, I don't know, the gut or the how would you guys call this in a non-salivary site? There's some micropapillary architecture, right? You have these little popping off. Sometimes just mucinous adenocarcinoma, right? Sometimes like colloid carcinoma, right? Where there's just things floating in pools of mucin. So in fact, in salivary, this is mucinous adenocarcinoma. The interesting thing about mucinous adenocarcinoma is that I want to find the right thing here for you guys. I don't want to take you astray. I think that's just a keratin. That might be a SOX. Yeah. No, this isn't. I don't have the. No, this is what it is. So, what control tissue are we dealing with here? Prostate. Does anybody know what stain this tumor stains for that also stains prostate? NKX 3.1. So, salivary mucinous adenocarcinomas can have intra and or extracellular mucin, but not be mucoep, right? And have expression of NKX 3.1 and not be prostate, right? These people don't have prostate cancer. So that's kind of an interesting little tidbit, a little clue, that it's salivary type mucinous. These are rare, but now that we know they exist, we are seeing them more and more often. Some of them have AKT1 gene mutations. I don't think this one did, but many of them do. Another example of the exact same diagnosis of mucinous adenocarcinoma is one that actually kind of looks very papillary cystic and has these cells with giant red nucleoli that that was NKX 3.1 positive, right? It was like, oh, is this a metastatic prostate cancer, right? Because of those cherry nucleoli and the NKX 3.1. But this had the AKT mutation. This was in the cheek, right? This is in the buccal mucosa. And even though it didn't have these colloid pools, right, it has a lot of these tall kind of columnar cells that are probably, right, secreting the mucin into the extracellular space. So mucinous carcinomas of salivary can have these various types of looks. Questions?
Yes, I think so.
Yeah, they're PSA negative. PSA P negative. Just NKX 3.1 positive.
This is the two cases you showed of like prostate,
On what?
like morphological look like prostate.
Yeah.
Do we, like, would we still call it, like, do we have any concern that maybe prostate metastasis if the patient does have it?
Yeah, I mean, if the patient has prostate cancer, yeah, you always can consider a metastasis. If you find the AKT1 mutation, no, it's primary because I don't believe prostate has that mutation. So exclude that the patient doesn't have a primary prostate and or include the presence of the AKT mutation, and that'll be diagnostic. But yeah, it should be, these are PSA P negative. Okay, it's 9:03. There's only, oh God, I don't know what you want me to do. I can just quickly tell you what these are and you can look at them on your own if you want, or what do you want me to do?
Maybe I take back what I said about thyroid on
Take back.
Thursday. Sorry.
Whatever you guys want.
I wanna know what they are.
You wanna know what they are now? Okay, you wanna know what they are now. All right, so this is a mucosal site with sheets, right? Sheets of badness, mitotic figures, open coarse chromatin, necrosis, right? So now we are in the, this is a high-grade salivary carcinoma realm, right? Beyond that, what matters? Does it have a targetable mutation or fusion? Does it have anything that they can treat, right? You're calling this a high-grade carcinoma. It has these interesting kind of cribiform-ish spaces with central necrosis. So a lot of people have come up with the differential diagnosis of what in these tumors? What? Salivary duct could be an option, but for salivary duct, this is not apocrine, right? Usually salivary duct is very apocrine. This is kind of monotonous and non-specific, and it has this luminal pale material in it. So that might be a clue to the diagnosis, right? This luminal pale material and this otherwise monophasic neoplasm. Whoops. This stain that just went away from me. Is S100. The other stain that's going away from me, that intraluminal secretory material, right? This is mammoglobin. So this is high-grade secretory carcinoma. Doesn't like these stains. They may care because of NTRK therapy. They may care because of NTRK therapy. In many high-grade salivary neoplasms, they are asking us to do androgen receptor and HER2 because in some cases, right, they could be positive even if it's not salivary duct, and then they could treat the patient with androgen and Herceptin. But in this case, it's negative, but it is ETV6 NTRK. Wow, there's like a poltergeist here in the slides. All right, let's try that again. All right, this guy, core biopsy of parotid, you will see this. 100% you will see this, and well, maybe you won't see it because the poltergeist has gotten hold of the screen.
I think just refresh the web page.
Just refresh it. my God. Anyway, did you guys look at that core biopsy and what did you think?
Basal cell adenoma or
Basal cell adenoma, why did you think that? You're right.
because they were like the cells were basaloid and they were like it had that jigsaw appearance at low power
Mm-hmm.
and that's my fault.
I think this might be a lost cause. I can send you guys out the answers. Yes, that was a basal cell adenoma with nice S100 positive stroma in the background and beta-catenin expression. Here's beta-catenin by IHC. Okay, so this was a frozen of it. This is the resection of it, showing the same morphology with these beautiful tubulotrabecular basaloid structures and this spindled cellular S100 positive material. So BCA, BCA, BCA. Versus basal cell adenocarcinoma, the only difference is it has infiltration, right? So mostly the similar tubulotrabecular morphology, hyaline basement membrane materials in the form of these little globules, and right infiltration out into normal. So that's the only difference between BCA and BCA. Adenoma versus adenocarcinoma is basically infiltration. And then the last one was kind of a tough one, but it was a high-grade spindle cell thing with myxoid stroma that we were all thinking was going to be a myoepithelial carcinoma, right? Because it was, it's secreting this connective tissue bluish mucin. It's positive for, in this case, we did do keratin, right? It's positive for keratin because it's so spindled. I don't know what it is. It's positive for keratin. It had some weak calponin, but it had UV signature. So it was metastatic spindle cell squamous cell carcinoma from scalp with this very sarcomatoid myoepithelial-like phenotype, right? So always expand your horizon. And then I think, did you guys get this last one on a core biopsy?
No,
What?
it wasn't in the.
It wasn't in the presentation. That's fine. You'll get it. You'll get it on the final slides. And maybe you can appreciate how these are duct forming, and maybe it's not a great core biopsy, but there's a plump myoepithelial cell layer at the background. And if you look at the resection, you might be able to find that there are these more eosinophilic luminal epithelial cells and these very clear myoepithelial cells. Here's a great example, right? Here's a little lumen, and then all of these. So this is epithelial myoepithelial carcinoma, right? Which very, very, very characteristically has these prominent, optically clear myoepithelial cells in the background of these scattered ducts. So you can walk yourself through the immunostains for our favorites, right? P40, CD117, S100 kind of again stains a lot. This is like a myogenic marker. There we go. These are your, I think this is SMA, these are blood vessels, right? So just to prove that these actually are, myoepithelial differentiation. Anyway, so this is epimyoet. I've got so many more salivary tumors, we can spend 5 hours on them. But these are you are going to see these, right? These are the ones you're probably going to see. All right, questions, comments? I guess we do thyroid then on Thursday. And if there's any openings, I have more salivary. If you need me to fill a spot, I can fill with more salivary tumors. All right. Thanks, guys. And I guess I wasn't sharing for the last part of that. Sorry, people.